All right, so let's get started. More people are joining, but so welcome everyone for this, the first installment of the Generative AI Coast-to-Coast seminar series. My name is Jing Liu. I'm the executive director of the Michigan Institute for Data Science at the University of Michigan. So I'm going to share my screen and do a quick introduction of this seminar series. All right. So as all of you know, the people who joined today, as you all know, generative AI really sort of has taken the world stage in the past few months very, very rapidly. And so many academic researchers have already started exploring how to use generative AI in their research, whether it's about increasing productivity, whether it's about accelerating their current research or enabling new ideas. And so several data science and AI institutes in a second, I'll introduce all of them, work together to put this series together because we think this is the time where we can help the researchers generate new ideas together, think about collaboration, learn from each other's examples, but also consider important factors when adopting a very new technology into their work. So the purpose of this series is really to explore the research use of generative AI and as I said, build ideas and collaboration. We'll have 4 webinars in the next few weeks. Each webinar will feature 2 speakers from 2 universities. We have built in extensive audience discussion time and also invited audience members to submit questions ahead of time. But in a moment, I'll tell you, our original thinking really wasn't working because there were a lot of people who signed up. So audience discussion is going to be challenging with this many people. Anyways, but first thing first, I want to also give credit properly to the background image that you're seeing here, which is generated in Midjourney. As you can see, this is the prompt that I used, and this is the image that I got. And as you all know, generative AI, a lot of it really depends on the prompt. So if I use a different prompt, same prompt, I just added in Studio Ghibli style. This is what I get. All right, so I want to first thank all the collaborating organizations to make this webinar series possible. These are really the data science and AI institutes from Johns Hopkins, the Institute for Data Intensive Engineering and Science, Translational Data Analytics Institute from The Ohio State University, Ken Kennedy Institute at Rice University, International Computer Science Institute, eScience Institute at University of Washington, and Michigan Institute for Data Science at University of Michigan. Also, I want to thank all the organizers from these 6 institutes, Leah Shanley, Kathy Smith, Sarah Stone, Ani Thakar, Beth Wilbur-Cedar, Rachel Sutton, and also Angela Wilkins from Rice University. This is healthcare and public health is today's focus. I will introduce the speakers in a second. And then August 23rd, we have the next session, Generative AI in the Lab. Then 28th, we have a conversation on policy ethics in generative AI. And then last but not the least, August 31st, we'll have sort of a computer science view of generative AI and their potentials and issues. So So today we have two speakers in the healthcare and public health domain. So the first speaker will be Mark Dredze, who is the John C. Malone Professor of Computer Science at Johns Hopkins. So Mark develops machine learning and natural language processing tools to analyze social media data, patient record data, and so forth to better understand health behavior, inform public health policy and interventions, and to support patient care. So his research impacts many significant public health issues, including suicide prevention, gun violence, attitudes toward vaccination, tobacco, and so forth. And his work has been featured in many media channels, including NPR, the New York Times, the Washington Post, and CNN. Then we have our second speaker, Abraham Flaxman, who is an associate professor at the Institute for Health Metrics and Evaluation at the University of Washington. So his research covers a wide range of health topics, including various chronic diseases, substance use, mental health, health disparity, health economics, and so on. So currently, he's involved in a major global burden of disease study, which is a systematic effort to quantify the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, and geographies. So both of them are today's speakers because they really are sort of the pioneers experimenting the use of generative AI in research. So we're really grateful that they have agreed to do this. The audience members come from many different universities and also the public. So throughout this webinar series, the audience members will be hearing new ideas, new research. So we've even had some people wondering, what they should talk about, what they should not, because it's too new. But it's all exciting. Before I pass it on to Mark, I want to give the audience some ideas how we're going to the Q&A. Please do put your questions in Q&A anytime during the talks. We've already received lots of questions during the registration. So there's no way 30 minutes will cover all the questions. And the audience participation part is also uncertain. So what we decide to do is at the end of both talks, I will ask the questions on behalf of the audience based on what we receive during Q&A and on your registration form. I'm not going to ask every single question. I'm going to ask a few groups of questions. While the speakers answer these questions, audience members, if you want to chime in with comments, please raise your hands and our staff members will try to unmute you and let you join the conversation. However, with 30 minutes, there isn't a whole lot of time for us to address each issue very intensely. So we also welcome audience members to put your comments, your thoughts, in response to any of the questions in Q&A or in chat. And after today's webinar, we'll sort out all those comments and send the summaries back to all the attendees. So with that, I'd like to invite Mark to share your screen.
Hi, everybody. So first of all, let me just say thank you very much for having me. It's really a pleasure to be here. I think this is a great topic. This whole series is a really exciting time. I'm thrilled to see that Hopkins is involved in organizing it, and I'm happy to be here representing Hopkins in terms of the talk today. I like to start out with a picture of Baltimore. We have a lot of exciting things happening in Baltimore. So it's a nice picture. All right, so what do I want to talk about today? I'm going to talk about language models in medicine and some of the really exciting opportunities that we're seeing today, but also some of the challenges that I think we're going to be facing in coming years. Okay, so I guess I want to just say the goal here is how should we think about using language models in health and medicine? And I think there's a lot of excitement. A lot of people see potential in different ways, but the medical space is really different from a lot of other application areas in which we might want to use generative AI. And so it really requires a different way of thinking about what are the real challenges and opportunities that we're going to face in this space. I'll also say the next speaker is going to focus more on public health. So I decided to focus more on medicine, clinical health in this talk. So I think most of us or all of us are familiar with ChatGPT, which I think woke up a lot of people to where AI research was and the potential for what it could do. Of course, ChatGPT is maybe the most well-known example, but there are many, many models now that many of which are publicly available and quite excellent for doing this type of language modeling and this type of AI, right? So this is not just one model, it's a whole space of models, and there are many more, all tuned for different settings or different purposes. And so I think many of us are familiar with kind of the really exciting kind of creative potential of these models. So here I asked ChatGPT, write a poem about Mark Dredze giving a talk at the Michigan Institute for Data Science Generative AI Coast-to-Coast webinar series, and the poem should be in the style of Dr. Seuss. I'm not going to read this. I'll leave it up there for a moment if you'd like to read this Dr. Seuss poem. The point, I mean, I'm not going to claim this is great poetry, but the point is these models are incredibly flexible. They're very creative, and they have a lot of capabilities that we are still exploring and still trying to understand. What are the capabilities of the models that we already have, and what is the potential of where these models can go with further development? Many people have played with these models for medical applications. And so this is a pretty simple case. I wrote to the model, I have a sore throat and headache. I'm not running a fever. It hurts to swallow. What are the possible diagnoses? And the model does a reasonable job of actually providing you some idea of what might be going on, right? And it goes through, well, you might have a virus, you might have an infection, or it might be an allergy. Okay. And so this might not have been the goal of developing these models, but it's pretty clear that they have some amount of knowledge of medicine. And so the question has been, since then, how we can use these models in medicine. How can we use these models to advance medicine? And there's been a number of models developed specifically for the medical case. So one is a model called BioGPT. This came out of Microsoft almost a year ago. This is a model that was trained on the biomedical literature. So it has a it has a familiarity with the biomedical domain. It's not specifically in clinical data, it's just general biomedical data. This is another model that's much smaller, but similarly trained. This is a collaboration between Stanford and Mosaic. This is a model trained on PubMed data, which is also biomedical data. There are two models of the same name, clinical-T5 and the clinical T5 that come out in the past couple months. And these are a bit different because they're actually trained on clinical data. So these are patient notes and exploring the potential of how well models can do when they're trained on that kind of data. These are a different kind of model than the GPT series, but they have a lot of the same capabilities. There are reasons why you might favor one over the other. MedPalm is an adaptation of Google's Palm system. So Palm is Google's version of ChatGPT. You can actually now interact with it. They call the public version, I think, Bard. Maybe I'm wrong about that. I can't remember. Something like that. Or no, Palm. I don't remember. I don't remember the branding, but whatever. You can go on to Google's website and play with the model. And they adapted that model to the medical domain and showed it did very well in a lot of medical tests. So there's a lot of work going on here, not just in evaluating these models for the clinical and medical domains, but specifically building out models for those domains by using data from those domains. So what can these models do? So here's an example question from a data set that is commonly used to evaluate medical models. So this is a question taken from, it's either taken from or it's adapted from the US medical licensing exam. And so these questions basically present the test taker with some kind of clinical case and then ask for a decision, right? So we describe a patient who comes in, they have some symptoms, this is their history, these are the exams that were performed, which of the following are likely to happen, right? So these have been, the models I just talked about have been evaluated on these types of data sets. So this is what it looked like at the end of 2022. Don't worry too much about the numbers here. I just want to give you a sense of progress. So MedPalm at that time was doing much better than other models out there. They say, this is actually from Google's, this chart. So they say 60% is like the pass rate of the exam. Okay, fine. They updated Palm or MedPalm with MedPalm 2 a couple months later, and it got much better, right? And this trend has been steadily going on where models are getting better and better over time. So it's pretty clear these models have capabilities. You're already starting to see these apply to medicine. So there are companies that are starting up that are like Hippocratic AI and others, where they're exactly building models like this and trying to use them for healthcare applications. So this isn't a future potential so much as something that's going on right now and something that is moving very, very quickly. Models exist that do well on medical benchmarks, whatever that means. We can have a discussion of whether or not those benchmarks are good or not, but it's pretty clear that models are getting better at those benchmarks, and that there's a push to derive models specifically for the medical domain. And so the question then becomes, well, what should we be doing with these models, right? What are the real opportunities in medicine for which we want to use these models to either improve patient care or improve, make it easier for doctors to do their jobs, make their jobs better, increase safety, reduce medical error, save costs. All the standard things you hear about in medicine are potential goals for how we might want to use these models. So there's really big opportunities, and I'll just point to my own paper just as an example of this. So we did a paper in, I think this came out in like April-ish, yeah, April. And we did something that we thought was pretty simple at the time. We took questions written by individuals that were medical questions. We took answers that were written by physicians posting to public forums. So we know that these are physicians, but they are posting it not as a doctor. They don't have a separate doctor-patient relationship, but they have, they're seeing the questions, responding to them. And then we took those same questions and we gave it to ChatGPT, and we took the answers from the doctors and the answers from the model, and we simply compared them, right? And this paper got a huge reception. That's what the figure on the right is, just to show like how many people are talking about it. And if you look at the responses, you could see that it's pretty obvious why our annotators who are licensed medical professionals thought that the ChatGPT responses were better, right? So if you look at just like the second question here, question about need to see a physician following injury that occurred by hitting head on metal bar. So we're not listing the question, but we're telling you what the question's about. And the physician response is things that signify you should see a doctor, and they have a list, right? If you develop any of these things in the next 24 hours, rush to the emergency room. I think this is a fine response. I think this is not a surprising response if I said, you know, I wrote a message to my doctor, this is what they sent back. This seems reasonable. If you look at the ChatGPT response on the right, it gives a lot more details, right? So it says, it's always best to err on the side of caution. Head injuries are really serious. Here are things to look out for, symptoms, where you were injured might be, might matter. Here are some things to look out for, and it has its own list, what to do in the meantime. So 100% of our evaluators thought that that chatbot response was better. We also asked them not just to rate the quality of the response, but the perceived empathy of the response. So reading these responses, which seems to indicate more empathy. And overwhelmingly, people thought that the chatbot was expressing things that are associated with empathy. You can see on the next answer here, I'm sorry to hear that you're bleached, that you got bleach splashed into your eye, right? The chatbot is very good at saying those kinds of things. So the reason I highlight this paper is when we wrote it, I kind of said to my colleagues, like, yeah, this is kind of an interesting paper. And I can see over the next couple of years, developing out language models for this task. Specifically, can we help doctors answer patient questions that they get through their EHR system, right? Like messaging that patients send to doctors, right? Which has become very, very common now, especially in the wake of COVID, when there was a shift to a lot of this telemedicine and a lot of people started submitting questions. Before the paper even came out, we had this announcement that Epic partnered with Microsoft to integrate GPT into their EHR system, and they're already rolling it out of hospitals. And so this was really amazing to me because it just showed the demand for this type of technology and the speed at which this was progressing. That we could take an idea that if you had asked me, I said, yeah, it has potential, it's worth exploring. And before the paper even appeared, it's already being put into production, right? I'll let you decide whether or not that speed is a good thing or a bad thing, but it is certainly there. So what are the potential for using language models in this space? So one thing is to do things that we've been doing for a long time with clinical data, but just do them in a faster, easier, better way, right? So there's a lot of tasks that hospital systems do on their data to try and organize their data, secondary use, for example. And this basically is a series of extraction tasks. So does this medical record talk about certain drugs, certain topics, certain diagnoses? And you might want this because you want to do research, or you might want to ensure certain safety protocols are being followed. And so these types of models are a really good way to spin up very quickly systems that do that kind of extraction. They seem to do a pretty good job of it, and this is an ongoing area of research, and they do it kind of out of the box almost, without a lot of investment of time. And so this is becoming a very attractive solution to provide a new technology for things that we're already doing in healthcare systems. Beyond that, there's a lot of places where we can actually potentially use these to actually improve medical care. So for example, diagnosis and treatment. This is always historically been a challenge for doctors. A lot of medical error happens in the diagnosis and treatment phase. Essentially, what is this patient, like what is this the disease that this patient has, and what are we going to do about it? The USMLE questions are meant, not all of them, but many of them are meant to kind of simulate this diagnosis treatment case. They're obviously much easier than what the challenging questions doctors often face. They also have the advantage of there's a clear right answer, and they give you all the information you need. But still, the promising performance of models on that task suggests that maybe these types of generative models can actually be used to analyze patient data and help clinicians make judgments about diagnosis and treatments. I already talked about the potential for improving patient communication, and that's, I think, where you see this already being deployed. Can we help doctors better address questions they're receiving from patients, and in general, provide better and higher quality information to patients, whether that's in person or by message? And certainly, there are research questions we have, and there are ways where we can see these systems both help doctors doing research and keeping up with the latest, but also helping to push the medical research establishment forward. Secondary use is a place where we see the potential here for a lot of research on clinical data. And I've mentioned things like evaluating the quality of patient care, ensuring safe care, certain standards being met, how do we improve care? And I think there's a lot of opportunity for these generative AI systems to be used in that space. It's also the case that these systems will be used by the consumer, by the general public. So everyone knows that Google is a well-used source for medical information, right? I'm sure most of us, if not all of us, have used Google or Bing or some other search engine to ask medical questions. And there's a lot of work into ensuring those search systems give you good answers. It seems obvious to me that people are going to start using generative AI systems and these chatbots as resources for medical information. I don't recommend you do this for a variety of reasons, but I also think we need to be aware that this is going to happen. And so we should be thinking about how we can use AI systems to support that, right? How we can ensure that answers that people might be getting from these systems to medical questions are accurate answers. I think medical education is another area where there's just a lot of potential here. I think in education right now, there's a lot of angst about the effects of these generative AI systems, mostly from the side of this is going to disrupt the way we normally teach, but it's in a negative way. But there's also a tremendous opportunity to use these systems to improve the way we teach. And that's certainly true of medical education. So for example, can we use these systems to mimic a doctor-patient interaction as a way of teaching doctors how to interact with patients and scaling it up to give doctors more experience or medical students more experience doing this. So right now, a lot of times it's done in group settings where you either have an instructor playing the patient or another student playing the patient. And obviously that's a really important educational tool, but there are ways we can potentially expand this and give our students even more practice by automating this a bit. Another area is feedback. So we try and teach students how to take clinical notes, but it's very hard to give feedback and to scale up that kind of feedback to a whole class. Can we use these systems in order to do that? Can we use these systems to help doctors be more empathetic? This is a real challenge for doctors who are really overwhelmed. And this is an important part of medical education of helping give students tools to be empathic and caring physicians. Can we use these language models as a teaching technique in that regard? So I think the opportunities here are enormous. I think they really touch on almost all aspects of the medical system. And if you just go to PubMed and you search ChatGPT or GPT or something like that, you will see a large number of articles in many journals already talking about the implications of this for radiology or pathology or for patient care and medical education, right? People are already seeing the potential. I want to shift to talk about the challenges, because I think that the challenges here, some of them are really unique to the medical space, and we need to be sensitive, especially when you're talking to people like me. So my background is in AI, my PhD is in computer science. I am not a doctor. And so I come to the medical space not as a doctor with hands-on experience, but as a technologist. And I think the danger is that people like me will see problems and rush ahead with solutions without really understanding the unique challenges present in the medical space. And so I think we need to be careful and really understand what those challenges are to make sure that when we deploy tools, we're actually seeing improvements. The medical system is famously complex, many examples of this. And we always need to be careful that an idea that sounds good actually, when it's interfacing with our complex medical system, where we have many stakeholders with often conflicting interests, that actually bears out to be a good technology. So I'll give some examples of challenges. The first is evaluation. Normally, the way that these models are evaluated, at least so far, is on answering medical questions or biomedical questions or clinical questions. And the reason that's the case, in some part, is because that's how we evaluate doctors. A board exam sits a doctor down and asks them questions. It's a little bit more complex than that, especially when you get to the step 3 exams. But essentially, this is what we're doing. It's not necessarily the case, though, that an AI system that is good at that is a good doctor. People and AI systems, they learn in really different ways. And the way we check that people understand a task and can do a task, that's not necessarily the way we want to check that a machine can do it. So how do we evaluate systems? So I don't think we should be evaluating medical AI systems in the same way we evaluate other AI systems, other natural language processing systems. We need to make sure that our evaluations are better aligned with the intended use cases, right? And that has a bunch of research questions. So, well, if that's the case, what are those use cases? How are we going to evaluate them? And how do we do this in a cost-effective and largely automated way? Every time we come up with a new innovation, do we need a team of doctors to evaluate it? Or is there some way that we can evaluate it in a mostly automated way that allows us to make steady progress on a problem before we actually try and deploy it clinically? Another challenge here is clinical data. And I think this is a really big open question. Most models that are being trained now for the biomedical domain are using biomedical articles. And the reason is because those biomedical articles have lots of information about patients, they have lots of clinical information, and they're relatively easy to access. Compare this to clinical records, which have HIPAA protections and all these issues. You can't just download a bunch of those and use them for training. All right. So what is the gap there? Is the utilization of biomedical records instead of clinical records, biomedical articles instead of clinical records, what problems does that lead to in the model? And how are we going to overcome that? And what are the challenges in terms of privacy and HIPAA that we need to face in order to do the sorts of things in the clinical space that you were seeing happen in many other domains? So training clinical models, I think, is an active area of research. There are some frameworks that might be specifically well suited to this domain. One of them was a paper from Google a couple months ago called, I think, EHR Safe, where they basically used a language model to generate synthetic medical data. And that synthetic medical data didn't have any HIPAA protections because it was all fake. And so we could use that kind of data to train models. That sounds great, but there's a lot of questions we need to answer, especially in terms of the biases present in that data, whether or not that's a good idea. I think another complexity here is simply working with the medical system. The healthcare system is far more complex than people realize. And it seems silly to say that, but there's just so many examples from a research standpoint, from a political standpoint, where you tell people the medical system is complicated. People reassure you that they know that, and then they try and do something, and they come back and they say, well, it was more complicated than I thought, right? So I really want to underscore this. The healthcare system is really complicated. And you need to understand that it has different stakeholders who have different challenges and different needs. You have providers like doctors and nurses. They're often overloaded. They just want to focus on the patient. They don't want to be replaced. They want to be augmented. How can we enable them to do a better job of what they really want to do? You have patients, right? We're all patients. What do we want? Well, I know I want more attention from my doctor. I want my doctor to listen to me more. I want better communication with my doctor. And I understand my doctor is overwhelmed, but I want that attention, right? I might have made an appointment, waited 3 months, I get 10 minutes with the doctor. That's the most important thing to me. How do I get that kind of attention? Hospital systems want something else. Hospital systems want high quality care. They want patients that are healthy, they're doing well, but they also want to be efficient and they want to reduce costs. There are ways in which these are synergistic, but there are also ways where these are in tension with each other. And when you're talking about deploying generative AI systems in medicine, you need to be aware of these stakeholders and how they're interacting. The reality is AI systems for health often fail because the people who develop them don't understand the medical system. And there's a very long history of this. A famous example, and you hear it a lot of times, is called alarm fatigue. And the simple problem is we are really good at building systems that find potential problems with the patient and then sound an alarm. And the reality is, in a modern ICU, there are so many monitors and there's so many alarms that they get ignored. And if any of you have ever spent time in a hospital room as a patient or visiting a patient, we all have the experience of seeing an alarm go off, waiting a minute, mentioning it to the nurse, and the nurse says, oh, just ignore that, right? That's not good. And that comes from this idea of people are building systems where they look at the system, they say this is good, and they don't really think and understand how that system is going to interact with all the other systems in the environment of the ICU or the hospital in general. There's often misalignment between the goals of AI and the goals of the healthcare system. So for example, there's an idea, I've mentioned it today, it's been around for a while, developing AI systems for diagnosing patients. And the reality is doctors, yes, they struggle with a certain class of patients and AI can help there, but doctors are really good at diagnosing most patients and they struggle only with certain types of patients, right? And so the AI really needs to focus on those cases. There are some examples more recently where people have developed AI systems for delivering mental health care. And also there's been some cases where people don't really like that, right? Like people might like the responses they're getting, but they don't like that it's coming from an AI system and it makes them not receptive to the care. The last thing I want to mention is regulation, or I guess the second to last thing I want to mention is regulation. This is not the web. On the web, you have an idea, you build an app, you deploy it, you see if it works. The medical space is very heavily regulated, and we really need to understand what that means. And this is also a challenging and evolving environment. So the FDA is trying to figure out, well, what are the guidelines that we should have for developing AI systems? But the point is that as these systems are being conceived and implemented and deployed, they need to understand what are the regulatory hurdles and expectations. And that implies or enforces certain requirements on building the systems, evaluating the systems, and deploying them. The last thing I want to mention, and it's not last because it's the least important, it's really important, is bias and fairness and of these systems. So in medicine, we often think about bias and fairness on single instances. Did that patient get treated fairly? Were the right things done for that patient? And when we're talking about automation, we really need to think about them on a population scale. Because when we look at individual decisions, we might see a fair system. But when we look at population level systems, we might discover systematic biases. We know these biases exist certainly in the US healthcare system and others as well. How do we ensure that AI systems are not making the problem worse? So we need things like accountability, right? If there's a joint decision being made by an AI and a doctor, who is responsible? And is that realistic? Are doctors willing to take on that kind of responsibility? That's a very complex interaction. Transparency. How do we know that these systems can explain their decisions? And explanations are really key for integration into the clinical environment. Doctors don't just want to know what the system thinks the diagnosis is, but why it thinks it's a diagnosis. And certainly ethics are a huge issue here. And you have to remember that in medicine, we have a long history of bioethics. This is not new. And AI needs to really turn to that history and understand it and use it as a guide for what we're doing. We don't want to reinvent the wheel here. We really want to understand what are the ethical issues in medicine, how are they dealt with, and how can we apply those principles to AI. So I see there's some questions come in. I'm happy to take questions during the Q&A session, and I really appreciate your time and attention. Thank you.
Actually, I would like to just let AB start his talk. My sense is if we start answering one question, that will lead to a lot of discussion. So let's try and save them to the end if possible. AB, I'll let you share your screen.
Great. Can everyone hear me? This is just so nice to be here to tell you about my perspective on generative AI in public health and some opportunities and risks. You're going to hear some unexpected overlaps with all the things you've just heard from Mark about generative AI in more individual medicine. To begin, I would like to acknowledge that this research was conducted on the traditional lands of the Coast Salish people. I'd also like to tell you about some of the grant and research support and consulting that I have done. None of this is specific funding for generative AI research. So I feel like I'm not the right person to define generative artificial intelligence, but also I'm a mathematician by training. Before I got into global public health, I was just obsessed with definitions. So I feel like I have to give it a try. So if we were to give a definition, maybe we could say generative AI refers to the use of artificial intelligence techniques to create or generate new content. That's what I'm going with for now. And if there's something that's more nuanced or that I'm missing, I hope I'll find out. The examples that I have in mind when I'm talking about this are like a lot of things we heard about in the previous talk. These large language models like Llama 2 and ChatGPT, visual models like Stable Diffusion, and going back to the first model that really made me like sit up and pay attention. This is going to be big. 5 years ago, StyleGAN came out and was able to make photorealistic images of photographs of people, but the people did not exist. I was at the time thinking, this is going to change things. And at the time, again, 5 years ago, when I was thinking about where artificial intelligence might fit in global public health, there was this AI luminary, Andrew Ng, who explained the capabilities thusly. If a typical person can do a mental task in less than 1 second of thought, we can probably automate it using AI either now or in the near future. And 5 years, is that the near future? We're able to do so many things that even a typical person can't do, even if you give them way longer than a second of thought. So when I was thinking about this 5 years ago, my colleague Theo Voss and I said, we should focus on AI automation for public health work that fits into one or more of these categories. People don't like doing it, or they can't do it fast enough to meet the demand, or they can't afford to do it. There's something that is just outside the scope of what we have resources for. And in global public health, we often have limited resources. So I'm going to organize my reflections on this into 3 areas: natural language processing, AI-assisted data analysis, and simulation with generative AI agents. And I'm going to try to weave a thread through it all using a specific case study that's been of interest to me over the years called verbal autopsy. So I'll just reflect on that case study for a moment and then get back into the different elements of it. Because as I mentioned, I'm a mathematician by training, and about 15 years ago, I made the leap into global health metrics. It's an area of public health that's very global in its scope and a very, quant metricsy focused in its focus. And the Global Burden of Disease study is kind of the flagship project of the Institute for Health Metrics and Evaluation, where I work and where I landed when I was making this switch. The Global Burden of Disease study is an attempt to compare how much health is lost for a comprehensive list of different diseases and injuries, and make these comparisons geographically and temporally. So you could say, for example, how bad is malaria in Zambia, and is it getting better or worse over time? And how does that compare to road traffic injuries? And is the situation in Zambia different than it is in Ghana? And to measure disease burden, we must know who is dying of what and where. And death certificates exist for less than half of all deaths globally. This would be a great source of information if we were trying to figure it out in the United States. But what about in Zambia, in Ghana, in many parts of the world? Well, verbal autopsy is a tool for filling this gap. And the solution that verbal autopsy posits is just ask. This is actually a picture on the left of a verbal autopsy happening. And what happens is a trained interviewer who is not a medical professional, perhaps, finds an individual who's familiar with the final illness that led to the death, and then asks them questions, 40 minutes, maybe an hour's worth of questions, like, did blank have a fever during her last illness? And how many days or months before her death did the fever start and end? And then based on this information, try to come up with the underlying cause of death. This is not a new approach, and it goes back to the 1950s and 60s. It was named by a group of field workers working on it in India, and it really came to global prominence when a report in the 1970s from the WHO suggested that lay reporting of health information by people with no medical background could be a way to find out what people were dying of. 50 years later, it remains one of the best available approaches for assessing causes of death in communities where most of the deaths occur outside of hospitals. And I'm just going to kind of throw back to this as we go, thinking about different ways that generative AI can be used across the board in public health, starting with natural language processing. So when I'm thinking about natural language processing, I'm thinking about automating ways to deal with free text. And we saw plenty of interesting applications of this in the first talk in this session. Free text is somewhat common in global public health data. And so when I'm looking at large language models, the specific part of Gen AI that I've really focused on for this talk with you, I'm thinking about how they might be able to make it easy to do something with this free text, which in the past has been kind of a pain to deal with. And so thinking about it in terms of verbal autopsy, the overarching challenge was to find out what people are dying of. The approach was to have lay interviewers ask someone who was present during the final illness. And the bottleneck to this approach, why it has not become the thing done everywhere across the world, is that there are not that many doctors available to take the results of the verbal autopsy interview and use their experience with the kinds of symptoms and the kinds of diseases in the place where the interview was conducted to determine what was the underlying cause of death. the few doctors who do have this experience have things that they would rather be doing with their time, like helping patients who are not yet dead. And so this is a perfect area to think about, can computers come in and help or take over doing this task that doctors don't want to do? Gates Foundation actually funded collection of a large database suitable for training and validation of these sort of computer certification techniques. It's openly available since 2011. And in that data, there was a lot of open text collected, which in the 2011 release, we didn't give out the full text because it said like, this doctor maltreated me at this hospital and stuff that was kind of touchy subjects. But I was subsequently able to get all of that information redacted and released as a de-identified database of almost 12,000 open-ended responses to verbal autopsies. And so this is the kind of thing that I'm asking, like very specifically, going back to the case study of verbal autopsy, thinking about Gen AI applications, can large language models do something that we previously couldn't do to understand what people are dying of in verbal autopsies? And just to give you a really concrete example of what I'm talking about, here is an example, verbal autopsy interview, just filtering down to the important stuff that was revealed in that interview. The deceased was a 53-year-old male, who was reported to have asthma, heart disease, hypertension, and had symptoms of ankle swelling, puffiness over the face and the body, cough that produced sputum, difficulty breathing, more than usual protruding belly, with risk factors of using tobacco, drinking, but a low amount of alcohol. And then in the free text, which I didn't put in this slide, but is a sort of narrative elaborating on this, that included keywords like asthma, breath, heart, lung, swell, and water. What I really miss about giving a virtual talk instead of being in the room with you is seeing like who lights up, because they've got that kind of clinical thinking and has an idea of what they think the underlying cause of death was. But I guarantee out of 150 people, some of the audience thinks they've got a diagnosis. So were you surprised? And those of you who didn't, I'll tell you, we know pretty well that the underlying cause of death from this validation data set I described is chronic obstructive pulmonary disease, COPD. And so this, to people who think about diagnoses, gives some idea of how hard it is to come up with this. But it's also something about how important it is, because understanding whether COPD is kind of a common problem that's happening in a population or something that's not as common could help us in planning what kind of public health prevention we're going to do, what kind of treatment facilities we're going to try to provide, what kind of research we want to get in the pipeline to come up with new ways to deal with these different diseases that impair health. And so you could imagine trying to get ChatGPT to answer a question like this. This comes down to this very underdeveloped area, prompt engineering, where you say like, okay, I don't know, you're GPT, a medical expert assisting researchers assigning a cause of death based on information. And we want you to give a cause of death from this list of options. And after setting it all up, we then give the free text. Here's an example of the full text, not just the keywords that would come out of it. And then ChatGPT actually can really understand this text and say, when it says at the end of the text that tetanus was a problem, that's consistent with everything that's happening in there, and saying the cause of death was tetanus seems like a pretty useful thing to say here. This is super relevant in global public health setting, because tetanus is a vaccine preventable disease. We can be thinking about the things that we could do, what went wrong to lead to this cause of death. I thought I'd just show a full, like, here's everything from a prompt. I don't know, basically in the audience who wants to see what's exciting, what's not. But one of the things I've been working on is trying to come up with a good way to ask this question and then extract information from the results. And there was a question in the Q&A from earlier I saw about asking about accuracy. This gets 25% accuracy in a straight ahead analysis with that validation data set that I told you about. Now, that's not exactly what I want, because the distribution of causes in the validation data set is not like what I'm expecting in a real world application. But just, you know, to give you some idea of what we're able to do straight off. It was very quick to do this, but it's not super accurate to do it. Now, state-of-the-art performance is not super accurate either. And so one of the challenges in verbal autopsy is its lack of accuracy. But while it was straightforward to prototype, based on some results I've been reading about, I bet there's better that we can do than trying to come up with a really good prompt and asking it in a chatbot interface to ChatGPT. And I'm really inspired by this finding from a paper by Cocone et al. Called ChatGPT, Jack of all trades, master of none, where they report on a number of different sorts of NLP tasks, task 1, task 2, task 3, read the paper to see what they are, and how well the prompt that they came up with to get ChatGPT to do the task compared with state-of-the-art performance. Basically, on the x-axis shows how hard the problem is based on state-of-the-art performance. And in terms of my verbal autopsy stuff, I think I'm on the harder side of the scale. And then how much worse GPT was compared to state-of-the-art, where, you know, typical performance was maybe 10 points worse for GPT, but you can see in some tasks, some of the tasks that were similar in challenge to what I think verbal autopsy is, GPT was way worse than state-of-the-art performance. And so thinking about, you know, how can we go beyond cooking up prompts to ask ChatGPT to solve these problems for us requires lifting the curtain a little bit to say chatbots are not exactly what we need for this. They seem close. They're something we can prototype quickly with, but at the heart of the chatbot is this large language model that really is, I think, an efficient encoding of a probability distribution, where we say, what's the probability of Wn+1 conditional on a bunch of previous Ws, where I use W because I'm kind of thinking of these as words, but they're actually tokens, not words. And this starts to get at why, you know, chatbots aren't really what we want, but also getting what we really want is a little bit of work here, because causes of death are not always tokens. Tetanus is probably a token, but ischemic heart disease is probably 3 tokens. And asking just what's the probability of the next word, focusing in on the words that we're interested in, even putting aside the question of words versus tokens, also doesn't exactly get at what we want, because first of all, there's lots of synonyms that are of interest here. And even though I've done all this prompt engineering to try to focus in on the ones that are terms I'm familiar with, I know from experience that other terms sneak in. And so there are some additional affordances that wrap this probability distribution. There's been a lot of talk about the reinforcement learning from human feedback part that goes from, say, a GPT to a chat GPT. A lot of the details of that are still a mystery to me and perhaps many people, except those at OpenAI. But then there are some additional affordances, just like how we take the prompt that I've given ChatGPT and then wrap that in some additional prompting to make the AI give a reasonable response. And now that there's some more open language models available, like Llama 2, we can start to see what might be happening beyond the sort of, at least referred to openly, if not fully documented, reinforcement learning from human feedback stuff. Zooming out a little bit, I think there's a lot of areas where generative AI could be useful, specifically in VA, right? The prediction part is a key part, but also, you know, it's a challenge that interviews take 40 or 60 minutes, and adaptive interviewing, possibly with an AI assist to help us focus in on the key points of the data to get better data and to get it faster, is a very appealing area. It's also very appealing to make these AI systems work in collaboration with physicians. I'm very hesitant to give any individual a completely automated certification of the cause of death of their loved one. I think that the system is not up for that kind of individual level feedback. This is really something I want for population metrics purposes. But if the AI system was working together with a physician, maybe it could cut the physician time down to something that was acceptable, and also give results that were vetted by a human expert and sort of available to individuals in a way that seemed safe. And finally, there's a sort of moral distress to this verbal autopsy work. You can imagine why it's an emotional topic for an interviewee to recall the final illness, around the death of a loved one. But it's also actually very hard for interviewers to do this. It just is something that day in, day out, hearing the stories of these worst experiences of individuals, and especially in a setting where you're not able to do anything about it specifically, has been documented to be pretty hard as to sort of work. So again, without a lot of great research or developed ideas, I put it out there as additional opportunities that seem like specifically in VA, and then probably more broadly, things that we might be thinking about. And then speaking of more broadly, there's across public health a lot of other sources of text data. You actually heard about some of the ones that come out of the health system in the previous talk, and I'm thinking of nurses' notes as another really important source of that information that might be amenable to large language model analysis. There's been a lot of interest in the global setting in using texting. mHealth is a term for it. And so a colleague of mine at the University of Washington, Professor Keshet Ronan, has been looking at advice during pregnancy for people living with HIV. That's sort of SMS-based advice. I don't think we're going to take nurses out of the loop on that, but perhaps large language models could help triage these SMSs and say, oh, this is something urgent happening with this pregnancy, and if you could get back to this pregnant person right now, that could be really helpful, versus, oh, another one came in at the same time, but probably if you get back to them today, that'll be fine. And then I think actually the previous talk really alluded to this in a way that I think is important for population health as well as individual health. There's just a ton of billing data that talks about basically what's happening between the hospital and the payers. This is in the US setting, but also internationally, where there's a little bit of a different system. And I often think of this as a sort of unnatural language processing challenge, like a synthetic language of ICD codes. But I think GPT understands ICD codes because they were in that big pile of data that it was trained on. And so this is another area where I think there's a lot of opportunity. I unfortunately have to speed up because I'm taking longer than I did in practice, getting excited about all of this. But I do want to tell you that AI-assisted data analysis is not the first thing that came to mind when I was thinking about using generative AI in public health. It was really that natural language processing stuff. But AI assist for data analysis, I think actually could be a bigger change in how we do this quantitative public health stuff. It is really a potential to broaden participation in the technical analyses that are central to evidence-based public health. And so continuing with this VA example, now I'm thinking about after we've collected the data, after we've used some human or a computer or a hybrid system to map it and get the underlying cause of death, then what do you do with that? I'll call that evidence at this point. But to go from evidence to knowledge to wisdom, to making change, to making some public health decision maker do something differently, there are so many steps in analyzing that data and preparing it and checking and cross-checking it. And computers can do that if people know how to program them well enough. But what's changing now is what it takes to be able to program it. I've got a real authentic example from helping a student who was doing an analysis and trying to figure out if she needed to impute the missing values from the rows that were missing, or if she could just drop them and focus on the complete cases, doing what's called the complete case analysis and simplifying things. And the question was just, wait, how many rows do we have where there's some column that has missing data? I know, like the back of my hand, how to do this in Python, but the biostats department has convinced students that they should be using R, and I know there's a way to do it in R, but I didn't know it off the top of my head, but ChatGPT does. And I think that this kind of AI-assisted programming, whether we're doing it just in a chatbot, saying, help us code in R, we want to find the number of rows where any column has a missing value, and it says, happy to help. Here's an example you can test with, and here's a cryptic line that does it, is going to be huge if we know how to use it right. And so seeing this, made me pretty suspicious. But can you explain how this works? And yes, chatbot certainly can explain how it works. And could you give me a code snippet there with some more details so it's easier to understand? And yes, I can expand on that. give you more details. Now, this was in R because this is what the student had already set to, but if you wanted to do it in Python, yeah, they could do it in Python. You know, this has the same challenge for people who aren't Python fluent. Use a Lambda function. It's kind of confusing, but yeah, it looks right. I think this is going to be a huge change in what it takes to be involved in this kind of quantitative technical analysis. I've got a second example that I'm not going to go through, but maybe we'll be sharing slides and you can check it out if you want later, because I was thinking when I was preparing this talk, should I use Llama 2 and just see how it compares to those ChatGPT predictions in verbal autopsy? Well, I haven't really kept it up with the Hugging Face Transformers library. My work has been more focused on the NumPyro library that has more affordances for Bayesian statistical analyses. But ChatGPT has, and it can help me figure out how to do things with the Hugging Face Transformers library, like find what is the probability of the next token for a specific prompt text under Llama 2, things that are kind of lifting the curtain even more than we did before, that you just can't do with a closed system like GPT-4. And the way that this is going to change things, I think, is going to be huge for people who are working in public health. I think it's going to be huge for how we should be training our students to send them out to work in public health. And I'm now thinking about it also from the perspective as a tool maker. How should I be writing libraries? And how should I be documenting these libraries so that in the future, AI assistants are going to be able to help my former students or public health professionals who I haven't had a chance to train and interact with when they want to use these tools in their own work? This is a very open question as far as I can tell right now. And so if people have thoughts on it, I'm very interested to know. The place that we're headed reminds me a little bit of this fantasy novel called The Wizard of Earthsea. This is perhaps too fanciful, but in the world of Earthsea, the study of wizardry is all about basically learning the true names of things, words in a language that is basically no longer spoken in the world of Earthsea. And maybe that's what it's going to be like in the future, to come up with the right prompts for generative AI systems, especially, you know, if the world moves on, but the knowledge in the Gen AI systems is locked in to what they were trained on in 2021 and 2022. I had an example that's not in the data analysis space, but it's kind of along these ways this weekend when I was playing around with some of my kids' friends with this stuff. And I said, you know, here's a poem thanking you for this fixing a Rubik's Cube you did for me. But wouldn't it be funny if we had flute music to go along with it? And with a prompt that doesn't say enough detail, ChatGPT balks. But because I had just read this great paper about sparks of algorithmic general intelligence, where a Microsoft team put GPT-4 through the paces in all these different ways, I knew that there was something called ABC notation. And if you say, ChatGPT, this is how I want you to do it, yeah, happy to give you a little flute music to go along with the poem it's just composed for a Rubik's Cube master. So the final point that I want to touch on is the one that I have the least developed thinking about, but is also one that I am really excited about pursuing personally. And that's because most of my time these days is spent on simulation modeling. And the global burden of disease I mentioned gives me these sort of baseline scenarios for calibrating individual-based models. But then I'm interested in saying, what if? So this is sort of a tracking over time of a simulated 65-year-old female who has high cholesterol and what might happen under different approaches to screening and treating cholesterol. The way I do this, I often try to avoid calling agent-based modeling because there's so little agency in the simulation so far. But working on this, and especially working on modeling during COVID, I've become convinced that modeling behavior, especially mass and elite behavior, this kind of agency that these individuals might have, are important areas for future innovation. This photo is showing a model that had a very simple look at behavior, basically phenomenologically saying, what if things that happen in the United States are like what happened in China, in Italy, and Spain in the early days of their pandemics, and what might happen in the future here compared to there. Now, the complexity of this is that the individuals being modeled are influenced by all sorts of things, in this case, getting to this really complicated feedback of including the predictions from models once they reach a certain level of communication. But even beyond that, just, seeing what's in the news or hearing from friends or hearing from constituents. And I haven't seen much work on this yet using generative AI, but there's one paper that's crossed my desk recently from a team at Virginia Tech, where Williams et al. In a paper called Epidemic Modeling with Generative Agents combine these in a pretty interesting way. On the right-hand side, they have a kind of traditional model, agent-based, individual-based model of spread of an infectious disease, where individuals are in a network, and if one of them is infectious, then there's a risk of transmitting to the ones who are susceptible to disease. But then they connected that to a ChatGPT-based decision about whether an individual should stay in or go out every day of the simulation. And that was based on health information about the individual's health, as well as environmental information about what they were hearing in the larger community about others' health, as well as personality traits. And it's a fascinating area to explore, like how are different sort of intrinsic traits going to interact with different individual health information and collective information to lead to different emergent behavior. I'm going to try to connect it to my verbal autopsy case study example, but I'm not even going to try. You can imagine doing simulation this way, even simulating verbal autopsy, which I think could be very valuable. In the interest of time, I won't go further on it now. I'm thinking about this very much right now because I have to teach a class this fall, Introduction to Epidemic Modeling. And so what should I include about simulation with generative AI agents? Well, maybe that paper from Virginia Tech would be a fun one for the students to look at. But this also goes back to my interest in AI-assisted programming, because these are public health students. They're not super interested in software engineering. They don't have a lot of experience with it. And that's one of the things that makes this class really hard for them, is that they have to learn enough programming to be able to construct their own epidemic models. With AI assistance, I don't know, maybe they don't have to learn as much. And so I'm going to close by saying, whenever we're thinking about this AI opportunities, we have to be thinking about the threats introduced by these new AI tech as well. And the ones that jump out for me in these three areas I've been talking about are, first of all, how they might bake in biases. We've heard a lot in the past about how large language models encode sexist stereotypes, racist stereotypes. Specifically in the case of verbal autopsy, I'm concerned that they might also encode inaccurate stereotypes of disease presentation and have a hard time recognizing diseases with less standard presentations, which might be related to more systemic inequalities in health and might be a way of further entrenching these sort of health disparities. Regarding the uses in data analysis and simulation, I'm also really concerned about a lack of understanding. If I teach my students how to get code out of a chatbot, that runs the risk of them using code that runs, but that doesn't do what they think it does. And using chatbots in AI is this fundamental tension. The whole point of having a simulation model, so I said AI, but I meant in simulation. The point of the simulation is to make things simple enough that we can have this sort of stylized model and generalize findings from it. If the chatbot is so opaque that we don't know what it's doing and why, then it's going to be hard to use a simulation where we can feel confident that the results are generalizable. And so that is where I will end for today. Thank you so much for your attention. Again, my name is Abraham Flaxman. I am avidly interested in this right now. So if anyone wants to continue the discussion, please email me, abie@uw.edu. And this picture is for people who might be bummed out by hearing so much about disease and death. I know this is an audience that's not entirely health people. if you're down thinking about the ends of life, remember also puppies. I'll leave it there, and I hope we have plenty of time for discussion.
Thanks so much, Abraham and Mark, for the two wonderful talks. And I'm sure everybody is feeling somewhat the same in that the next few years will be very exciting, but very uncertain. And so the hope is people like you and many people in the audience, we're all going to be working together to help shape how AI is used for the society, in a good way. So we have about 18 minutes for questions and discussion. What I like to do is I put some of the questions into three main categories. Let's use several minutes to discuss a little bit in each category. Rachel, I'm going to ask you to share the slides for the first set of questions. I want to start by saying that some of the questions that people ask today, more about regulations and ethics, these are incredibly, incredibly important, but these are also common for the use of generative AI in any field. So I want to downplay this side today because on August 28th, we have a webinar focused on ethics and regulation. Today, I want to ask the speakers and audience to think about three sets of questions that are more specific for the healthcare and public health. So the first set of questions are use cases. Mark, you mentioned various data that can be used to develop generative AI models, domain-specific models. What are some of the challenges for developing such domain-specific models on health data? What are specific types of research that generative AI is especially amenable for or has already been implemented? And also, what kind of new possibilities can generative AI open in research? For example, specifically, somebody asked multimodal applications in healthcare. Again, for audience members, I want to mention two things. One is please keep putting questions and comments in Q&A. If possible, we'll unmute audience members for you to add comments, but be sure that just be assured that after this webinar, the comments and answers will be compiled and sent to you. Also, the speakers have been answering questions in chat, in Q&A as the talks went along, and those answers will also be compiled and sent to you. So which one of you want to start trying out these questions?
I can go. So in terms of the challenges of developing LLMs for health data, so I think there's some challenges that we know what they are and we don't quite know how to solve them, and there are other areas where we don't even know what the challenges are. So I'll give you some examples. Traditionally, when you talk about training a language model, the first step is get a bunch of data and train on it. And if you look at how these big models are evaluated, they're using large dumps from the web. The new models from Meta are trained on 2 trillion words. And we're good at that. And so if you said, oh, I want to do this for the clinical domain, the first thing is, okay, can you get that much data of clinical record and train on it? And that's where you hit your first wall. Very few people have access to very large repositories of clinical data. Even if you have access, running a model on all that data is not entirely clear if you can do that for policy reasons. And then the resulting model, there might be issues with who has access to that model given the data it was trained on. And so how useful is it going to be? Can it be distributed? What it can be used for? So that whole pipeline has questions. I think there's also a question of how necessary any of this is. So keep in mind, models like MedPalm are not trained on clinical data. They're trained on data from the web. Now, data from the web includes medical records. There's certainly example medical records. But I'll say you can go to ChatGPT now and ask it to write a progress note for whatever you want, and it does a pretty good job. So there's really an open question about how much clinical data do you need in order to even train these models, and we don't know. We know that there are many issues of representation and bias in the training data. These issues become much more sensitive when you talk about clinical data, and the data at different health institutions reflects different populations and has its own biases. So there are multiple levels of challenges here when you talk about training and developing these models. Number two of like specific types of research, especially good at, there's so many. I'll just give one example that I think is particularly promising, which is summarization. So these models are actually really good at summarizing information, and that's actually a pretty useful case for the clinical setting. So one example people have is a doctor opens a patient record and wants to know, has this patient ever been prescribed medication, this family of medications, for example. The ability to type that in and get an answer, because the system can read the whole medical record and answer it, that's really attractive. And so I think that's an area where there's many use cases of summarization and question answering that we can see. In terms of new possibilities, I think that's an example of one. I think it's really, this is, I really think, an open question. What are ways where we can do entirely new things, not just make doctors more efficient or improve existing types of care, but what are entirely new ways that we can practice medicine or organize our healthcare system around AI, and I don't know what that's going to be.
Yeah, I echo a lot of those points. I think that privacy and confidentiality, a huge challenge, both in the individual health and population health. And there's both the real legitimate concerns about privacy and confidentiality, and then they're using it as an excuse, which, I've had years of people saying like, oh, there's these great techniques in differential privacy. Can we use some theoretically guaranteed privacy to get some data sharing for these great sources of data that people won't give us? And well, we probably could find a way that is theoretically secure to share it, but that's not why they don't want to share their data with you, So data is power, and getting both the technical pieces and the, let's call it strategic or aligned incentive pieces to get these things trained is a big challenge. These biases and also safety points that Mark brought up in his answer and his talk, I think, should also really be front and center. And then, yeah, both of us were very much like large language models, text as data kind of in our focus. But I think calling out medical images in this 1B question is another really exciting area. And I will be here early for all of the other talks in this series. Maybe we'll hear more about some other areas of generative AI besides text. And then, just thinking about other new possibilities. I mean, I think that it's a great opportunity to be thinking about, what are the things that we can't do because we don't have the time, or we can't afford to pay for it, or it's just too much work for humans to do. And is there a chance that we can now automate some of those tasks? And is it simple? That was the other point. When Andrew Ng says we can do it, he meant he and his team could do it, but the barrier to entry has become much lower as we have these kind of like general purpose chatbots where you can just give it a try.
Okay, so let's move on to the second set of questions. Rachel, I'm actually going to ask you to refresh the slide deck because I've added a few questions on the next slide. Maybe you need to, go back to the, and then go back to the present mode. All right, so The next set question is really reliability and quality control of generative AI's output, right? Things such as how do we understand the AI's work and its reasoning process, how to evaluate the output. Somebody asked how to assess the source of erroneous results, bias, where does the bias come from? Somebody asked, well, can models assess, is there any model out there that can assess and report their own confidence level? And also how do we evaluate errors that are clinically significant and clinically insignificant? Multiple people asked about AI hallucination, and somebody also asked, have there been any precedents like this, a new technology that is very much a black box? So how about this time, AB, you go first.
Oh, well, there's no way I'm taking these all point by point. So Mark, I'll make sure to leave you plenty of time for them too. But, my reaction is I don't want to ascribe too much agency to these large language models. It's just making things up. So when you say like the AI sometimes hallucinates, the AI always hallucinates. Even giving it the credit of that it sometimes hallucinates is thinking that it has some sort of vision. It sees things that are real. No, it's just banging around in a Markov chain, coming up with words that it thinks is the next word based on the words it's seen before. The fact that this looks like it sees things is what's amazing. And so this showing AI's work and reasoning, it doesn't reason. It doesn't show its work. It's just this one weird trick that moved from GPT being like a researcher's parlor trick to 100 million people signing up for it. If you say, show your work, it gives you a really good continuation. Why? Nobody knows why. As far as I know, I don't think that we have a good understanding of this. And it takes me back to like when I was starting college and was excited about neural networks, and people said, neural networks, they sometimes work for things. And if they do, that's great. But if they don't, we don't know what to do. I don't think that's changed. It's just expanded a million times what they can do great. So we don't know what to do when it doesn't seem to work. And that's why my focus is on things either where we can't do well already, like verbal autopsy, state of the art is right on 50% of the examples we give it. So if we're right on 52%, we've improved on state of the art. Or things that we can test. And that's my plan for teaching these students who don't really want to learn how to program, how to use AI assisting their programming, is to shift the focus from like, here's how you get syntactically valid R code to how do you test something that a computer gave you and you can press run and get results from. And I think that focus on like what's verifiable that comes out of AIs is the approach I'm going to take for starters. Any open-ended task where it's like, AI, could you write this section of my grant proposal or this introduction for a paper I'm working on? Like, it makes me doubt the quality of the writing to get it out of an AI. And it makes me doubt my own writing and everything else I read that's like, just sends me down this rabbit hole. So my focus, at least for now, is going to be on things that either we've got a very quantitative way to assess, or we've got a very, let's say, an inductive or deductive way to very quantitatively assess. And I have no idea if there's precedent for this. I'd love to hear Mark's reaction. But the one thing it made me think of is the hype cycle. There is certainly precedent for a peak of inflated expectations. And for those of you who are not familiar with this, it's a way that this consulting company thinks about all new technologies. And they say, as we hear about it, we get more and more and more hype until we pass the peak and crash into the trough of disillusionment, which, if we keep talking about AI as what people are talking about it, is coming, guaranteed. But there's still going to be something useful here, and we will climb to the, whatever they call it, final phase, the slope of being a little bit useful or something like that. Over.
Yeah, so I agree. I'm not going to, there's too much here on one slide. I could just, I just prepare another talk and we'll come back tomorrow and I'll just do this one slide. So I'll say a common thing to most of these is essentially the question of the model is not good at things, and will it get better, or how it will get better. And I think in general, these models will get better, okay? But I don't think we should be building them into applications or deploying them in settings that assumes the model has to be perfect. We should assume that it will continue to have issues of the kind on this slide, whether or not it's inability to explain its reasoning in a faithful way, hallucinating, it makes it difficult to evaluate why it made decisions. We don't understand why it made the mistakes. These will continue to be problems. And so we should instead think about ways we can use the model where they are robust to those kinds of mistakes, either because humans are in the loop and validating decisions, or the information is presented in such a way that people can decide whether or not they trust it. We have many things like this already, right? So, for example, if I pick up my phone and I ask Siri to do something for me, and it misrecognizes my request and then does the wrong thing, I can figure that out because it shows me what it heard my request to be, right? So they said, like, look, Siri's going to misunderstand people and make mistakes, but if we just show people what it heard, then I can see, oh, it heard the wrong thing, and therefore it's doing the wrong thing. So we are very good at building systems that have AI components that have this kind of self-correcting behavior where users can correct the system or recognize when the system's making mistakes. That is very challenging to do, but I think that's how we should be thinking about its uses. I think the last point I'll just touch on here is the last on the slide. How do we evaluate clinically significant and insignificant errors? I think we're good at this in general. Like when we evaluate medications, for example, we realize that negative effects of medications are not all the same, right? And we validate and evaluate medications and say, well, this medication caused 20% of the people who took it to develop a headache versus this medication that killed 0.5% of the people. And we have ways of saying, well, one of those is better than the other, right? I think the challenge of doing that to these AI systems is that we don't necessarily understand how they work in terms of why they make the mistakes they make. And so when we talk about drugs, for example, we have models for how drugs function. We know if a drug causes this problem, it's likely to also cause this problem. That's where I think there's going to be a big challenge in evaluating these AI systems. If a system is making this kind of error that's innocuous, does it mean that it's more likely to make a really serious error or not? And I think that's going to be the real challenge here.
Okay, so we're 1 minute. We have 1 minute left. Rachel, could you go to the next slide, please? I'm going to make this really short. This is really important, though. Safety and quality of AI technologies. Many people put in chat very insightful comments, and you'll see these in our summary. Things like, when there are nationalized health services, would this be better? Who makes decisions about implementing which AI system or not? And things like insurance companies, how do they play into the politics of AI implementation? But because of time, I want to give each of you 5 seconds to answer a question here. Who are ultimately responsible for messages or diagnoses or any, clinical decisions generated by AI?
Right now it's the healthcare provider, and that's going to be a big problem. So if you're a doctor, okay, 10 seconds. You're a doctor, you're answering questions. Your hospital now uses the new Epic system. When you open a message, it's got a very long response that's already been generated. You can edit it and then you push send. You are on the hook for liability cases for that message you just sent. How do you feel about that if you're a doctor, right? I made you perhaps more efficient, but also, do you want to be on the hook for all of that information? I think we're going to find out what will happen.
I don't have,
Maybe.
I don't have the technical expertise to add to this. I think that the thing it just makes me think is that safety and quality are so fundamental. And we have to, really be thinking about if we're going to have systems that can make the hospital safer, if we're going to have systems that can make people feel like they've had a better experience, then I think that is a benefit. If these systems are all about how we can squeeze the health system even further, then, I think that looking in public health, but also in plenty of hospital settings, it just really stretched thin already. And there's some big risks to technologies that are gonna try to stretch even further. So a very interesting time we're heading towards.
All right, so we need to wrap up now. Thank you so much for both speakers and for the really engaged participation of the audience. This is such an important area of research and also application in every way. So people asked about where to find videos and where to find notes. They will come soon. You'll get an email about where you can find these things very soon. So thank you so much for this wonderful session, and hope to see you guys in our next few webinars as well.
Thank you for having me.